Hi, this is Hallie. I'm going to record your peripheral vascular system lecture. This is the second part or second component to the cardiovascular lecture. This will focus on the pulses and the peripheral vascular system, basically how well the heart is perfusing the rest of the body. So that's kind of where we're going. All right, exam gown and gloves would be necessary. Exam gown because we do have to get to some of the places on the body that are normally covered up by clothes. Gloves can be opted for if you're always worried about coming in contact with body fluids, or if the client may have something contagious, so on and so forth. A stethoscope may be necessary, and a blood pressure cuff in the clinical setting. To measure the blood pressure, and again, we don't teach that per se in this course, but they do address it in fundamentals. I feel that the more we rely on those automated cuffs, which are great, but students typically don't learn the technique of how to really properly take a manual blood pressure. And there are a lot of times when we really will need to do a manual blood pressure at times if your client is critically ill, if they have a really low blood pressure, if we're about the accuracy of the machines. A manual is always a great skill to have and to make sure you know how to do properly. In the clinical setting, if you're worried about any type of cardiac issues, and even on some cardiac floors, they do like to have the blood pressure measured in all four extremities. You don't just have to do blood pressures in the upper extremities. You can also use the lower extremities. It's just most often we use the upper extremities. Systolic for normal healthy adults, that's that top number on the blood pressure reading. We like it about 120 or even 110. Some of the newer studies say we really kind of want to keep that number a little bit lower. And anything, that lower number is called the diastolic number. And it currently says 870, or 80. But again, the newer studies are really kind of changing that down to about 110/70. They like to have a little bit lower blood pressure. It's really good on having that, lower blood pressure. It's a little kinder on the kidneys. You have a really very, fragile vascular system in the kidneys, and anytime someone has high blood pressure, it can affect those kidneys. All right, so the systolic less than 90, when that's that top number, if that top number drops less than 90, or if the diastolic drops less than 60, that is considered low. But again, we're always going to opt to see if your client has any other signs or symptoms, dizziness, so on and so forth, that might associated with what we call hypotension. That's when the blood pressure is low. You're always going to have a little bit of a variance. You can take a blood pressure, wait a couple minutes, take it again, and that's never going to be exactly the same. So you're going to have some variance, anywhere between 5 to 10 between the two arms. If you are doing a lower extremity blood pressure, that popliteal artery, which is behind the knee, it's usually going to be a little bit higher than the upper extremities, about 10 to 40 millimeters of mercury higher than the ones in the upper extremities. Just a couple things to keep in mind. You're going to feel for a pulse, and this is what you will do on your assessment, and you need to know where all your sites are and the names of those sites. A heart rate, again, for a normal healthy adult is going to be somewhere between the range of 60 to 100. Anything greater than 100 is considered tachycardia. Tachy meaning fast, cardia is the heartbeat. So tachycardia, 100 beats per minute or greater. Anything less than 60 in adults is considered bradycardia. Bradycardia, brady being slow, cardia again, cardiac. So slow heart rate, less than 60. Again, you're going to have to look at your clients. Some people tend to run a little faster. Some people may run a little slower. This is just a guide. You have to know what the normal range is for your patient. And you'll learn more about that when you actually get into the nursing program. This is just in general. If you're always not sure, we always encourage, and we really want students to do an apical pulse. Listen to that cardiac site at that fifth intercostal space, the midclavicular line. Listen to that for at least a full minute during their assessments and get a true apical heart rate and see if that pairs up with what they're getting on the Dynamap or the automatic blood pressure cuff or what's been documented, or if you even have a pulse deficit, which I talked about a little bit in the cardiac lecture. But yeah, you definitely want to check that apical pulse, just to review. All right, so part of our peripheral vascular assessment is to look at the periphery, which is the hands and the feet. The first thing we're going to kind of look at is inspect the hands. We like to kind of pay attention to those nail beds. And I know we kind of talked about it a little bit when we talked about the skin assessment. But remember, in a true head-to-toe assessment, you kind of just assess the skin with each system. When you're doing the thorax, you just assess the skin there. When you're doing the abdomen, you assess the skin there. When you do the lower extremities for your musculoskeletal system, you're going to assess the skin there. You don't do the skin assessment kind of like all by itself. We kind of incorporate it into all those other system assessments. So, and coming back to this, we're looking for the angle of the nail bed. This shows the normal angle of the nail bed. Most people have a nice little angle there. With people who have long-term breathing problems, typically COPD or emphysema, because the physiological changes in the body, their nail beds tend to get really swollen. Well, not the nail beds, the capillaries in the nails tend to get really swollen and having issues. And this happens over long periods of time. It's a chronic issue, and that will result in this shape called clubbed fingers. This is clubbing of the nail. Again, related to COPD, breathing problems. It can also have some other cardiac issues can cause clubbing. So we always want to assess for any type of clubbing and any type of distorted angle of the nail bed. Typically, you're going to see it more in the upper extremities versus the lower extremities, but we're always going to check for that clubbing. The capillary refill, you're going to assess bilaterally, both upper and lower extremities. You're going to look at that color of that nail bed. It should be fairly translucent. If they do have nail polish on, you can do the pads, the very end of the pads of the fingernails. You should have those nice pink warm undertones under the nail bed that shows that you're getting good perfusion. We're looking, making sure there's nothing dusky gray or any type of evidence of any type of cyanosis or lack of perfusion, lack of oxygenation. You apply pressure to that fingertip just for about 5 seconds, and it should turn pale. And then when you release it, it should pink right back up within about 1 to 2 seconds. We want it 2 seconds or less. If it takes greater than 3 seconds, that's considered decreased capillary refill. Sometimes that can happen if someone's really, really cold. But if they're in a warm environment and everything else seems to be within normal limits around them, there might be something going on with their cardiac output. Again, their perfusion is having a problem. So kind of consider your room where you're at. If it's really cold, if the client's really cold, you may have a little bit of a delay. But if they're nice and warm and you're still having a delay, there's definitely something to be concerned about. So again, we're just assessing whether it's normal or not normal. 2 seconds or less is normal. 3 seconds or more is abnormal. And I want to give the caveat about pediatrics capillary refill. Blood pressure assessment in pediatrics is really kind of not a great tool for assessing a true blood pressure in a pediatric client. If you get a really, really low blood pressure, we always worry that a patient might go into shock. But with pediatric patients, a blood pressure really doesn't give us that information like it does in an adult. It's the capillary refill that's really, really important in a child or an infant, any type of pediatric client. It's very, very important to assess the capillary refill because that is really a better determination of how well they are perfusing versus an actual blood pressure. So kind of want to throw that out there. You will learn more about that when you get into the nursing program as well. But just something important to remember. Again, if nail polish is covering that nail bed, just use the end of that finger pad. You should have the same result. All right, and then we're going to move on to assessing the peripheral pulses in the arms. Again, you're going to palpate the brachial pulse and the radial pulse. The brachial pulse is the one in the bend of the arm or there, kind of on the opposite side of the elbow. You're going to assess them bilaterally. And you're going to compare them from side to side. You're going to make sure that they are equal bilaterally. And then you're going to kind of grade it. And most people are about a 2. A 2 is a normal finding. Then you're going to assess the radial pulses. And that is the one just down from the thumb We call that proximal, just proximal, in the proximal location to where the wrist is on the thumb side. That's kind of what I'm getting across. And then you're going to grade the strength of the pulse. So typically somewhere between a 2 to 3 is normal for a healthy adult and children. If they have been exercising or something like that, you might get a more bounding pulse. If they are dehydrated or something like that, you might have a weak pulse. And remember, again, sometimes our geriatric clients, because of other underlying disease, such as peripheral vascular disease, maybe not so much in the upper extremities, but in the lower extremities, they can be weak, or they may even feel absent. But we would never, ever, ever document an absent pulse unless we cannot Doppel it. And that is using that Doppler that is usually available in the clinical setting. And we can expose you to that once you start clinicals. And again, we'd never, ever use our thumb, because you actually have a pulse in your thumb. You actually have pulsations in all your fingers, but the thumb is the one that's the strongest and the most pronounced. So I typically use my 3 middle fingers, and I lay it over the area and to assess the pulses bilaterally and get that strength and symmetry of the pulse. Nope. All right, an Allen's test. I'll just kind of briefly talk about this. This is something to just kind of talk about to assess how well the blood flow is in the hand or arm as regards to the radial and ulnar arteries. This is something really more a respiratory therapist might do before they do what's called an arterial blood gas. So we're not going to spend a lot of time on this. This is something you'll hear more about this later when you go into the nursing program. But you can certainly review a video on it. There have some videos on YouTube about Allen's test, but you have them just kind of place their palm up and make a fist, and then you compress both arteries, both on the ulna side and the radial side. And once that hand starts to go numb, because you've pretty much occluded all blood flow to the hand, you release one side, and you should have color return to the palm. And then you repeat the process, and then release the other side. And again, you should have blood and color return to the palm. If for some reason the color does not return faster or does not return appropriately, then you're always concerned that there might be something going on with the ulna or the radial arteries. The reason respiratory therapists do this is because they have to do, when they get arterial blood gases, usually they're going to pick that radial artery as a site to collect the blood. And as you know, if you ever puncture an artery, you have a strong chance of bleeding, because that's where the blood is being pumped to the tissues. So you have to, anytime you do a radial stick, or an arterial stick, you have to apply direct pressure for an extended amount of time. And if there is a problem with one of the arteries and you're applying pressure to the other artery, you might occlude any blood flow that the client may have. So that's kind of where the Allen's test comes in. Frequently, again, our respiratory therapists will perform them. I've seen them performed a few times. You can do it on yourself or on a client just to practice if you like. The legs. All right, moving on to the legs. Again, you're going to look at the skin color, hair distribution, and lesions. The skin color of the legs tells us a lot, especially in our older clients. If they have, again, that peripheral vascular disease, you can see a lot of things in the lower extremities. The skin should be uniform with the rest of the body, and it should also have some hair present in the legs, unless it's been removed. A lot of females obviously shave their legs or remove the hair on their legs. It also says check for hair on the top of the great toe. I know lots of females, they actually shave that part off as well, or remove the hair off their toes as well. But you usually can just kind of ask the client if they've shaved their legs or what have you. The hair should be nice and symmetrical. The concern comes in, and if you have like an elderly gentleman or even just an adult male that has some loss of hair to the lower extremities, again, there might be some underlying cardiac disease. And sometimes with that peripheral vascular disease, it will leave kind of like this discoloration. It's like a reddish brown. They call it a rusty discoloration, usually on the front side of the legs, lower extremities, the anterior tibia, and that's because of poor arterial circulation. You can see this a lot with people that have diabetes that's been poorly controlled, because diabetes will lead to vascular problems. So you can see this, and sometimes it happens on its own even without the diabetes. Ulcers are also present because of decreased circulation, and you can get ulcers because of arterial problems or venous problems. They do present a little bit differently. Again, you'll learn more about that when you go into the nursing program. But any type of open areas, wounds, or anything like that, you definitely want to measure and describe. You're going to compare the legs. Again, they should be symmetrical in size, and if you're really concerned about it, you can measure the circumference with a measuring tape at the widest part, typically around the calf. If there is some discrepancy, again, there might be edema, maybe there's an injury. There also could be the potential for a lymph problem or a DVT. But again, they should be somewhat symmetrical. You're going to assess the temperature in the legs using that dorsal aspect of the hand. Remember, the temperature receptors are much more in tune on the back side of the hand. And again, the temperature of the lower extremity should be equal and symmetrical. They might be a little bit cooler sometimes because, again, it's not uncommon for some people to kind of have colder feet, especially if and they're in a colder environment. If they do have some vasoconstriction because of the colder environment, they are going to be a little bit cooler. If it's a really warm environment, they might have some vasodilation, so it might be a little bit warm. If we're really concerned, like the environment's warm, the client's warm everywhere else, but their lower extremities are very, very cool, there might be some issues or some concerns with arterial insufficiency. When we're looking at the legs, we're going to look for any type of varicosities, varicose veins. There's also superficial thrombophlebitis, and that's usually like a little inflammation of the veins. We have them stand. Sometimes when they stand, it puts more pressure on them. It'll make them bulge out a little bit more. And sometimes they'll have some little nodules in them. With phlebitis versus an actual varicosity, phlebitis, how you can tell the difference is because usually it's red, warm, and tender, and it's a little bit more, it's a little more painful, and it has some warmth to it because it shows that there's some inflammation in it, whereas a varicosity does not. A Holman sign. This is something that we would perform for a client if we're worried that they may have what's called a deep vein thrombosis in the back of the calf, and you're going to learn more about that when you get into nursing school. But the technique is very helpful. The skill, unfortunately, is not always 100% even when it's performed at picking up an actual DVT. But you have the client laying on their back, you flex their knee back, and then you just kind of have them point their toes to their nose. You dorsiflex that foot. Again, if they have a lot of pain in the calf, we would be concerned that there might be a blood clot in the leg. And they would only do this for clients that have other symptomology that might indicate that they have a DVT or what they call a pulmonary embolism, which is a blood clot that goes to the lungs. Again, it's not consistent, but that's what they look for. The Holman sign, they flex that foot when the leg is at a 5-degree angle. And if they have some pain in their calf, there might be a blood clot in there. That's kind of what they're assessing for. Then we're going to move on to our lower peripheral pulses. Again, you're going to do the same thing, strength and symmetry, the peripheral pulses, and you're going to grade the strength. 2 to 3 is generally where most people are. If you cannot palpate the pulses, you would have to get a Doppler in the clinical setting. We know we don't have these at the school, and we don't have them at home, and we fully understand that. But in the clinical setting, if you are unable to Doppler or to feel a pulse on a lower extremity before you would document a 0, you would get your instructor, find a Doppler, and try to listen for a pulse. All right, so the lower peripheral pulses include your femoral, which is in the groin, the popliteal, which is behind the knee, and the dorsalis pedis. And if you think dorsal is top, considered top, pedis is the foot, so it's the top of the foot. Posterior tibial is just behind the tibia, so on the inside of that ankle bone, on the inside of the ankle bone, not the outside aspect, but the inside, that posterior tibial behind where the tibia is, not the fibia, the tibia. All right, so you'd assess for any type of edema in the legs and the feet. You're going to press typically in that lower extremity. As I usually go just above the ankle area, and you press down for about 5 seconds. And then you move your hands away, and you're going to look for if there's any type of evidence of pitting edema, and you'll see little fingerprints or indentations if that is true pitting edema. And then you would grade the edema. This is the grading scale. I believe you may have a question about this on the exam. It's usually 1 through 4. And how you always remember that, if it's a +1, it's going to be 2, +2 is 4. It basically doubles. +3 is 6, +4 is 8. So if somebody says that they have a +2, just automatically memorize, double it, it's going to be 4 millimeters. If it's +4, you're going to double it, it'll be 8 millimeters. So that's how you would grade your edema. You can have edema that is non-pitting. It's just really shiny and taut, but it does not actually leave indentations. It's just considered non-pitting edema. All right. On the feet, we want to look for the skin color, like the thickness and the color of the skin, particularly around the heels. The skin color and the nail bed should be fairly translucent. Again, if they are painted, you can use the pads of the very ends, the tips of the toes, the pads. And there should be no clubbing with the toes. Generally, you don't see clubbing the toes. Usually, something, again, you're going to see more of the upper extremities. With poor arterial blood flow, sometimes the toenails can thicken. They may even become yellow, and they may even actually fall off because of the lack of blood supply. That has to be pretty severe for that to happen. But there's other reasons for the toenails to thicken and become yellow. There's fungal infections and all kinds of other issues as well. But you're just going to do a general assessment. We're really looking for how it relates to the blood flow or the peripheral vascular assessment, how well they're perfusing the circulation into the body. Capillary refill of the toes, same process as you would do with the upper extremities. You're going to assess that bilaterally. Apply pressure to the toe, not says fingertip, but to the toe bed or to the toenail for at least 5 seconds, and that area under pressure should turn pale or white. When you release it, it should pink back up within about 1 to 2 seconds. If it's greater than 3 seconds, that's considered decreased capillary refill. And again, take in consideration vasoconstriction, the temperature of the room, if they have a history of anemia, because if they're already pale and have lack of hemoglobin as it is, it's not going to improve with your capillary refill. And again, if you have the nail polish, just use those toe pads. Geriatric variations include thickening of the heart walls, and just like everything in the body, the more it's used, it's just not as efficient as it used to be. So there may be some thickening of the heart walls, particularly that left ventricle. Decreased elasticity of the heart. It just doesn't pump as efficiently as it used to when it's a lot younger. The apical impulse may be a little bit difficult to palpate because of that AP diameter, and we can discuss that a little bit later. The location of those heart signs, we talked about the PMI. If you have somebody that has scoliosis or kyphosis or any type of curvature of the spine, that may alter where that PMI is as well, in conjunction to if there is some type of heart problem. So that is also something to keep in mind. Those murmurs are actually fairly common. They're not too uncommon in geriatrics. While it's not a normal finding, you hear of them more frequently in the elderly population. There is a cardiac rhythm. It's a heart rate, kind of how fast the heart beats or what the heart's beating. It's called atrial fibrillation, and that's all you really need to know about it for right now. But it is the most common irregular heart rate for elderly clients. And every student at least has 1 or 2 patients, if not more, of someone that has had a history of atrial fibrillation before they get out of nursing school. It's very, very common. Although it is an abnormal heart rate, it is very, very common. Sometimes they have some decreased hair growth on the lower extremities because of their arterial insufficiency. That happens frequently with that geriatric client. And having the rigid and tortuous, the varicose veins is uncommon. It's a little bit more common in females than males. And that is about that. Here is pictures of the pulses. If you look here, this is a carotid. Remember, 1 at a time. You don't want to try elicit that reflex sympathy where they might be bradycardic or asystolic. So one at a time. This is a client, it was kind of hard to tell. This is someone laying down, and this is their arm. This is where the brachial pulse is. And this is the hand. If you look here, the hand, and this is where the pulse is for the radial side. And then here is the dorsalis pedis. Basically, you kind of go in between these two toes and go up a little bit, back about 2 inches, depending on the size of their foot, and you're going to feel right up there. That's called the dorsalis pedis. This is a very important pulse to feel. This one's actually felt more frequently than I see people doing on the ankle. So this is the foot, the inside of the ankle. This is the tibia that comes down. This is the malleolus of the ankle, the malleolus, excuse me. Just behind that ankle bone, you should be able to feel a pulse. This is called the posterior tibial. And this is a knee, and this is the other knee. They have the knee bent up. It has to be relaxed because you really have to get up behind that kneecap and really kind of dig in there. This is one's kind of difficult to assess sometimes. It really does take some practice. This is the Popliteal Pulse. And then this one here is obviously the Femoral Pulse. We typically just do this pulse when we do our abdominal assessment because we're already assessing the abdominal area as it is and feeling for the bladder and the lymph nodes. So this is that for the this is the Femoral Pulse. Notice they are wearing gloves for that one. Here is your concept map. If you have any questions, please let me know. Thanks.